Results. The taxonomy. So remember I was talking about Bloom's taxonomy and how boring that is and how I think the model sucks because it doesn't include predictive ability. I'll try to get back to that in a moment. The taxonomy of generic questions included 69 categories. The three most common types, the three most common types comprising 24% of all questions were: what is the cause of symptom X? What is the dose of drug X? And how should I manage disease or finding X? Maybe I'll read that again, but I want to overlap that research from 25 years ago with exactly what I'm talking about now in this video. What those statements represent, what those findings represent, is that doctors had been trained to go from perception to action, but without the intervening understanding. So as you all know, if you look at medical textbooks, so for example, like in my case, I've looked at a lot of medical textbooks because I went through 3 doctorate programs and I had to study pathology 3 times. Not including independent study, which of course I've done, but also that doesn't even include the kind of personal time study used for studying for board exams, etc. So what I noticed every time I had to study pathology is that the diseases were described almost always as idiopathic. So if we don't have a foundation of memorized data, then we will be told, or we will tell ourselves, or the books actually tell us, that we can't understand these conditions. They're idiopathic. I think it's idiopathic. And that's exactly what's going on here. So the appropriate approach to clinical care would be perception, understanding, and action. That understanding, the intervening understanding, requires a very broad knowledge base that extends beyond what is taught in medical school, medical training, and studying for board exams. So those are, in the medical world, and well, I guess maybe in all worlds, those are the sources of information accumulation other than experience. But what is experience other than the application of the knowledge that was gained? The sources of knowledge are medical school education, which doesn't talk about nutrition, and which also teaches students that most diseases are idiopathic. Medical education, postgraduate residency training, which is just slave labor with very little actual education involved. It's mostly doing. It's doing with a little sprinkling of information on top, but the amount of detailed learning that takes place is close to zero. So you've got formal medical school, postgraduate hospital residency, and then studying for postgraduate exams and attending postgraduate seminars, etc. None of those talk about nutrition and functional components that would be required to have a really good understanding from which a doctor could then go step 1, perception, step 2, understanding, step 3 to action. My argument for years has been, and I'm just now kind of putting it together in a more solidified manner, my argument for years has been that, and maybe it was based on this because I did see this 25 years ago. My argument has been, and the argument that has been made and established, is that doctors are trained basically to go from perception to action. A lot of times in medical practice too, doctors only have 5 to 10 minutes with a patient. So they don't have a lot of mental time to process what's going on and then, provide like a customized treatment plan. That doesn't happen. It does happen in the chiropractic and naturopathic and kind of boutique medicine worlds. But in fact, I actually have a document from my hospital training years. I actually have the document somewhere. It's actually right behind me. I think I'll try to put it in this video when I edit it. I've cherished my good luck in the fact that I kept this document. But proving the fact of what I just said, that doctors only have 5 to 10 minutes. When I was studying internal medicine in hospital postgraduate hospital work, they actually told us, don't spend more than 5 minutes with your patient. They actually wrote that in the training document. I'm so glad I kept that. I think it's right behind me. Maybe it's not, but if it is, I'll include it in the video. I'll take a picture of it and drag it into the video. So very briefly, these were the instructions that I received when I was in family medicine residency in the United States after graduating from medical school, also in the United States. So, people talk about, or they glorify this bullshit postgraduate training, but look at the reality of it. I'll just show you on the following page. So again, these are the actual papers that I received, and I was shocked by this when I saw it, and I'm still shocked by it. Do not spend more than 5 minutes with the patient. So, what level of complexity is a young, inexperienced intern going to gain? And what level of complexity are they going to engage? These are hospitalized patients. So imagine having a elderly hospitalized patient who entered through the emergency department and is now hospitalized for however many days. And a young intern is supposed to go in there and try to figure this out and develop a treatment plan in 5 minutes. I just thought that was absurd, and I still think it's absurd. Also, as an additional side note, in this same program, so this was internal medicine. So in this same internal medicine rotation, the director of the internal medicine program that I was in, one day we walked by a patient's room, and he didn't go in. He just signed my notes that I had done, because I had done the physical exam and the treatment plan. He just signed my notes, and we kept going. And he says, "You know why I signed your note?" And I had some idea, but of course I had to say, "No, tell me, sir, why you signed the note without seeing the patient." And he said, "Well, that's so I can bill them, even though I've never seen them." So that's basically what he admitted as we're walking down the hall, is he basically admitted to me that he's committing Medicare fraud, because he was signing the notes on these patients, but he had never seen the patients. And so that's the level of training in accredited postgraduate residency programs in the United States. So basically, again, doctors are specifically trained to go from perception to action without understanding. Proof of that, number one, is that most medical textbooks say that diseases are idiopathic, and all you can do is just drug the hell out of these people. Number two is the evidence demonstrated here in this clinical practice study showing that the most common questions asked by doctors are, what is the cause of the symptom, which is identification. So we go from identification or perception to action, which is we're already prescribing drugs. Boom, we go from, oh, you have diabetes, oh, you need insulin. Oh, you have diabetes, you need metformin. Oh, you have high blood pressure, you need a beta blocker. And then a little bit of management, which is pretty much the same thing as action. So what this article documented is that doctors think in terms of perception and action without really understanding things. Further proof of the lack of understanding is the fact that that understanding would require more than just diagnosis and drug. Doctors would need to have a more functional not simply pathology-based understanding of what they're seeing. And that, by definition, would require some study of nutrition. And we all know what's been well documented for decades now is that nutrition is essentially not discussed and intentionally ignored and denigrated and insulted within the medical world. So again, in the second 15 minutes of the video that I spontaneously recorded, I talked about event models, and I spent a few minutes talking about accurate versus inaccurate event models. A poor event model is perception to action, which is how doctors are trained. And in emergency medicine, that's great because, you know, the pathophysiology of emergency medicine is mostly straightforward. You're looking at infections, trauma, and acute events like stroke and heart attack. So in certain emergency-based settings or urgent care settings, the understanding is relatively straightforward, and you can go from perception to action. And perhaps arguably should go from perception to action. However, and this is the argument that I'm making, acute pain management, which I also just described right now, you can kind of go from perception to action. But for chronic pain management that by definition involves so much more complexity, it requires understanding, which requires a more functional education, which also happens to thereby include nutrition. And not simply nutrition, of course, but a more functional and complete understanding. Let me change colors. I guess I'll go to a dark green. So what I'm arguing ultimately in later parts of that video is that this deeper level of understanding would require, for example, the things that I talk about in Inflammation Mastery, 4th edition. And that's in the Functional Inflammology Protocol. So it's all laid out and diagrammed, etc. And I'm going to update that diagram just slightly, just to make it a little more explicit. But it is certainly clear enough as it is. It's on the cover of the book. I mean, all you have to do is look at the cover of the book, and you can see the model. And you'll notice that all of the things that I emphasize, and I talk about drugs a little bit in the book, so I can't say that it's completely separate from the routine practice of medicine. But the topics that I emphasize in the book, the 7 main topics, or the 7 components of the protocol, all of those are not discussed in medical training. So I talk about food, infections, and dysbiosis. Obviously, infections are talked about in medical training, but dysbiosis not so much. Nutritional modulation of immune function is not discussed in any aspect of medical training. Dysmetabolism and dysfunctional mitochondria. And then we get into stress, psychology, sleep, exercise, etc. The endocrinology section of my protocol, part number 6, is actually pretty straightforward. I mean, I don't really talk about anything radical. I look at the 6 main hormones. Obviously, we have more hormones than simply 6, than only 6. But I talk about, the 6 or 7 main hormones and how to optimize those levels. And that's not radically different from what you could find in a good endocrinology textbook, if it's a good book. And then xenobiotic immunotoxicity, of course, and neurotoxicity, that's not discussed in the practice of medicine. So, these things do exist, these fields of study outside of what's taught in medical school. These things do exist, and they are important. And in fact, as I just said, they form the basis of my protocol.